Case study of a 70-year-old man presented by Immaculate Kumi, Regis College. 70-year-old man with a history of congestive heart failure, COPD, and hypertension. Currently smokes 1 pack of cigarette daily. Takes lisinopril, digoxin, and Symbicort daily. Married to a wife of 30 years and is retired. Previously an accountant, is supported by adult children and lives with his wife in the home. A case study of a 70-year-old man presented by Immaculate Kumi, Regis College University. 70-year-old man with a history of congestive heart failure, COPD, and hypertension. Currently smokes 1 pack of cigarettes, takes lisinopril, digoxin, and Symbicort daily. Married to a wife of 30 years old and is retired. Previously an accountant, is supported by adult children and lives with his wife in the home. Presenting symptoms: chest pain, shortness of breath, flank pain, and fever. Differential diagnosis based on the above symptoms can be chronic obstructive pulmonary disease, angina pectoris, and pyelonephritis. COPD. According to American Lung Association, ALA, chronic obstructive pulmonary disease, COPD, is a combination of long-term bronchitis and emphysema that affects the lungs, making it hard to breathe. The symptoms include breathlessness or shortness of breath, or you can call it air hunger. This disease comes with increased work of breathing and coughing resulting from impaired gaseous exchange and sometimes pneumonia. Dyspnea is a state of breathlessness characterized by expiratory wheezes. Dyspnea is also the primary symptom that limits exercise in patients with advanced COPD. Angina or chest pain results from oxygen deficit to the cardiac muscles. There is chest pain that may not be angina and that will quickly be resolved by any pain medication. The chest pain related to angina pectoris can only be resolved by nitroglycerin. When oxygen supply to the myocardium is impaired, the heart works even harder and increases oxygen demand. Also, the short supply of oxygen to the cardiac muscles causes ischemia and causes pain. Respiratory diseases such as COPD can cause oxygen deficit, so angina and COPD are related and can present themselves in a patient that has the primary diagnosis of COPD. Pyelonephritis is an upper urinary tract infection. Urinary retention in older men is a predisposing factor to urinary tract infections. Pyelonephritis happens when infection from the urethra extends to the kidney or from a systemic blood-borne pathogen. It may involve one or both kidneys. The areas mostly involved are the renal pelvis and the medullary tissue. The infection triggers inflammation, phagocytosis, and necrosis with byproducts of sporulent exodus filling the pelvis. Venous and arterial circulation is severely obstructed and can result in acute kidney failure. The inflammation usually results in a dull, achy pain in the lower back of the flank area, which is consistent with one of the symptoms of my client. Recurrent or untreated infections can cause fibrosis, scarring over the calyces, and can even result in chronic renal failure. Now, another symptom my client is presenting with is fever. When the inflammation is triggered and phagocytosis takes place, necrosis and exodus starts building, the complementary cascade is triggered even as the pathogens increase in number. This immune response triggers fever. So the pyretic status of my client results from the triggering of the complementary cascade. Summary. The differential diagnoses are close to the possible cause of the symptoms manifested by my client. The patient has a history of congestive heart failure, COPD, and hypertension. COPD predisposes patient to oxygen deficit, thus patient is likely going to be prone to angina attack resulting from impaired oxygen supply to the myocardium. Hypertension predisposes the kidney to ischemic crisis that could result in nephritis. Untreated nephritis might advance to pyelonephritis. Growth of resident bacteria related to urinary retention could result in a systemic bacterial invasion. Flank pain is consistent with signs of pyelonephritis. Fever is the hallmark of infections related to immune response and the triggering of the complement cascade. Diagnostic tests and treatment. Some diagnostic tests that could be used in this case include chest X-ray, MRI, abdominal X-ray to view the extent of damage to the kidney and the myocardium. EKG can also be used to rule out any form of dysrhythmias that may occur. And blood work is done like the basic metabolic panel, BMP, to trace the level of BUN and creatinine. UTIs are diagnosed by dipstick urinalysis tests using clean cache mainstream or catheter urine specimen or urine microscopy. This is usually followed by culture analysis to isolate the bacteria type to test antibiotic Diagnostic tests and treatments continue. Some treatments that can be used in this situation include albuterol breathing treatment via nebulizer, supplementary oxygen via nasal cannula, antihypertensives, sublingual nitroglycerin, antipyretics, anti-inflammatories. UTIs can be promptly treated with antibacterial drugs such as Bactrim, nitrofurantoin, cephalosporins, carbapenems, amoxicillin, and fosfomycin. Complementary treatments for UTI could also be employed, which include natural therapies such as cranberry juice, D-mannose, vitamin C, and Chinese herbal remedies. Hydration and diet changes has also been helpful in enhancing healing in patients with UTI. References. A total of 4 references were used in this presentation. Thank you for being part of this presentation and have a blessed day.